الحين is good.
Yep.
Very good. وجلستي زينة؟ لأنك أنت تشوفوني ترى أنا ما أشوف.
هي لا تمام، كله تمام، الله يعطيك العافية.
Is it good?
السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بالجميع. إدارة الشؤون الأكاديمية وتدريب صحة الطائف ترحب بالجميع بلقائنا اليوم. لقائنا بالتعاون مع مجمع الملك فيصل الطبي بصحة الطائف، ممثلة بقسم العيون والبصريات. طبعا حتكون معنا اليوم البروفيسور الدكتورة سلوى الهزاع. طبعا هي معروفة، ما نحتاج نعرف فيها، ما شاء الله تبارك الله، يعني نفتخر فيها الدكتورة سلوى دائما في جميع لقاءاتها اللي هي تطلع فيها، ما شاء الله تبارك الله. طبعا دكتورة هي أستاذ بكلية الطب جامعة الفيصل، أستاذ كلينيكي بطب العيون كلية الطب جامعة جنوب كاليفورنيا، كبير الاستشاريين في طب وجراحة العيون، كبير الباحثين السريريين، واستشاري أمراض العيون الوراثية والشبكية، عضو سابق بمجلس الشورى. تفضل دكتورة، مايك is yours.
Hello.
أي دكتورة. دكتورة.
أنا معاكم. Somehow we were disconnected.
Okay.
But I'm back now.
Okay. نحن قدمناك يا دكتورة للجمهور. تفضلي دكتورة، المايك معك.
شكرا عزيزي. السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيد النبيين. أولاً أحب أشكر وزارة الصحة وأشكر الكينج فيصل ميديكال سنتر والدكتور سامي الحارثي for allowing me to share artificial intelligence in the healthcare. As we know, since the COVID-19, many things have changed within the country. And I think the most important thing is, even though the COVID has been a more or less a pandemic, but it has shifted gear where now we are more or less in the need of anything that's virtual and at a distance, especially when it comes to the patient care. Many of the routine patients should not be seen in hospitals or by doctors if this can be done. So during this time period, we have actually worked on what we refer to as SARIA, Saudi Arabia Automated Retinal Image Analysis. And it's just simply saving sight through artificial intelligence. And we are now using it in diabetic retinopathy. If you allow me, for those of you that don't know what artificial intelligence, machine learning, deep learning, let me just spend a couple of seconds explaining it. The artificial intelligence, it's also called the الذكاء الاصطناعي. It's their programs that can sense, reason, act, and adapt. Under the artificial intelligence, there's something called the machine learning. So the machine learning is simply you feed it algorithms, it takes it, it analyzes it, and then it technically, whatever you teach it, it learns it, but it does it with the help of the humans. The deep learning, for those of you that have heard the deep learning, and they should not be used simultaneously with machine learning, I always consider deep learning as an evolution of machine learning. So what it does is you feed it, and when you feed it all this information through the algorithms, it's an advancement to machine learning that it can actually make decisions on its own depending on what you give it. So if we look at SARIA, so if you look at SARIA, the artificial intelligence is now considered the buzzword in ophthalmology. Everywhere around the world, people are using artificial intelligence. The UK is actually considered the forefront of all this. Currently, it's focused on diabetic retinopathy. That's where the advancement is. And all it is, just remember the word algorithms. And it's based on deep machine learning. So if we have the artificial intelligence and you have all this machine learning, and then you go further into deep learning, we run into a big problem that we have all this data. How are we going to analyze this data? Who's going to take care of this data? This is where the Saudi authority on data and artificial intelligence comes in. So they've been really a very big support. So This is what it is. Machine learning, as we mentioned, you keep giving it, you feeding it, and it just does the classification and it will give you exactly what you give it. Whereas with deep learning, it actually goes further into the neural and it can actually make decisions on its own. So very different from machine learning. All right. So now that I've explained a couple of minutes on machine learning, what can on artificial intelligence and deep learning, what do we want to target? Why did we pick diabetes? We chose diabetes because at the moment right now, there are 425 million people living with diabetes today. They're expecting by year, we're expecting by year 2040, it will actually increase to 624 million. All these diabetic patients, and for those of you that are in the ophthalmology healthcare, all these patients, they need to have diabetic retinopathy screening. Worldwide, globally, only 55% are screened. In Saudi Arabia, and these are peer reviewed, only 24%, unfortunately, are being screened. So, what do? How can we get all these diabetic patients screened? And you have to remember,
Humbly
diabetes now,
request for me to moderate this session.
diabetes now, there's a voice behind. Diabetes now, unfortunately, is called the silent pandemic. So how do you do it? The only way to be able to diagnose these 425 million patients globally is automation, because it keeps growing and there are not enough specialized ophthalmologists or healthcare to be able to screen all these. If you look at the WHO, it has categorized Saudi Arabia as the number one in the Middle East for diabetes. And it's actually categorized it, the WHO, as the seventh highest prevalence of diabetes in the world, and the first among the developing nations. The WHO has declared that we have 10 million patients with diabetes. I know it's a number that's flabbergasting, but this is actually documented. And I was actually challenged by someone in the Ministry of Health, but I simply told him I have gotten this from the WHO. So we have a total of 3 pre-diabetics, 7 million diabetics, which totals 10. If we look at diabetes, what are the consequences? You know, you have the stroke, you have the congenital heart disease, amputation, heart failure, nephropathy, but we want to concentrate on the retinopathy. So if you look at it, the Saudi diabetic population, 20% will have some sort of retinopathy. 11% will have proliferative retinopathy, which is considered sight threatening. 6% will have macular edema, which is again considered sight threatening. Why do we want to leave the traditional screening? Why do we not want to, stay with the traditional screening? Because one, it's human resource intensive. You need many, many employees to be able to meet the patient, dilate the patient, see the patient. Then you need a doctor, a specialized retina person to be able to do a proper diagnosis, or someone that's trained, even if it's a general ophthalmologist. Another thing, what's the limitation, is the waiting time. So not the waiting time when he comes to the clinic, but the actual waiting time to get his appointment. And then the waiting time when he comes to the clinic. So you decrease the patient satisfaction. The cost, it's very expensive for him to come, for him to travel, to take his son, his daughter, his wife, his anyone, he actually from the absentees from the work. So now it's not only the patient, because the patients are usually blind, unfortunately, their vision is down, but the absentees and having to take off from work. And then last but not least, it has to be hospital based, because that's where the specialists are and that's where the treatment is. We shouldn't have to be limited by these traditional screening. What SARIA does, and this is what we refer to as the Saudi Arabian automated retinal image analysis, you don't have to do all this. It doesn't have to be in the hospital pre-SARIA. All you need is a photo, and you throw the photo to the cloud and you get the results without anyone needing to be present that has expertise. So what's the benefit of early detection? And these are courtesy of Dr. Adel Awaifer. They're screened early. If they're screened early, you get them green. They still have their vision and you get a lower number. But by the time they get into the system, by the time they're referred from the Ministry of Health, they're already in the red. So they already have vision threatening or sight threatening, and they have increased. So if we list the 5 complications that diabetic patients are most concerned about, I'm not saying vision loss constitutes 40%, but if you ask patients, he doesn't mind his leg being amputated, but once you talk about vision, he worries. So they did a beautiful survey and they found out that they're mainly concerned about 40% were concerned about vision loss, whereas only 17% for the cardiovascular, 16% for amputation, 13% kidney disease, and then 5% for the neuropathy. So you can see that the vision was really important. What's the alarming facts about diabetic retinopathy screening? Globally, less than 1 in 3 patients are screened in time before they develop the vision threatening. In Saudi Arabia, it's actually 1 in 4. 21 of patients have never had eye screening. That is really, that's alarming. That's globally. For us, it's actually it's more than 60%. Why? There are not enough eye care specialists to provide this screening. Another important thing is obesity is the leading risk factor for type 2 diabetes. And you have to remember, between us and Kuwait, we tend to be the #1 globally. One time it's Kuwait, and then one time it's Saudi Arabia. There was a beautiful survey that I've been following that was done by the Barometer report. And why did patients do not come for their visits? Long waiting for the appointment. It takes them a long, they can't find an appointment. Some of them say they're expensive. They don't want to have to pay. A long waiting on the day of the visit. When they come, they're crowded in the hospital. It's a bottleneck. The eye exams are not available near my home. And I think DIAF is really one of the most important things. This is why they're utilizing the telemedicine, limited access to diabetes, and the list goes on. So when you sit and you talk to people and you say artificial intelligence, they say, yeah, we are doing telemedicine. These are totally 2 different, they are not the same. Because yes, you take photos of these patients. The doctor doesn't have to be available. The photos are then, this isn't telemedicine. The photos are then sent to a reading center, which means the patient takes the photo, goes home, and waits for someone to call him back. So here's the reading center. The doctor has to be available. Now, I will tell you, for most of the retina specialists are not going to waste their time in reading centers. So you tend to get the juniors who are not as experienced. So therefore, the quality decreases. And then you get the report. By the time this patient has taken the photo, and by the time it's sent to the reading center, by the time the reading center reports back to the dispensary, by the time the dispensary calls them, it can be anywhere from a week to 1 month, which is not reliable. So when you think of telescreening or telemedicine, it uses remote human graders, and it's wonderful in the past, but now things have changed. First, it's expensive. Why do we say it's expensive? Because you're taking the reader's time. Instead of him examining patients or treating, we don't even want to examine anymore as retina specialists. We only want to treat. At first, it's expensive because you're utilizing his surgical skills where he could be treating patients, and there's always a delay. So what we have to do is artificial intelligence. It's the point of care screening. The patient comes in, he gets his result immediately. You use the fundus camera, and now the automated solutions have been deployed by many health systems. So automated diabetic retinopathy screening is essential. So artificial intelligence can be leveraged. Why is it so important in diabetic retinopathy or in ophthalmology? Because of the retina. The fundus camera can take a picture of the retina, anything that can be taken, and then it's given through machine learning. Remember I told you machine learning, and then you have the deep learning. So then it's sent and you get it directly. I'm going to be talking more about this. If it comes out as red, it's referable. If it's green, you don't refer the patient. You tell him go home. I'm going to be explaining. And this can be performed by a primary care physician, a trained optician, optometrist, even ophthalmologists that don't have any expertise in diabetes. When the diabetic patient comes for his exam, his general exam for his diabetes, there should be a camera there. He should finish from his general exam, go to the camera, get this taken, and be able to be told, go to the hospital, get treated, or go home. You don't have to worry about your eyes. So automated image recognition, they can save time. They free the specialist time. We should, at this stage of time, we should be doing therapeutic intervention instead of diagnosis. Why not let this repetition of diagnosis be done by a machine? So this particular application that we have customized to the Saudi population has actually had 500,000 patient exams. There were 500,000 patients were examined. 2 million images, retinal images, were analyzed by deep learning. And it's now used in 5 continents: UK, India, Germany, Italy, Norway, and Armenia. Of course, I didn't write the States. It's also being used in the States. So why not bring it to the Kingdom of Saudi Arabia, especially since we have 10 million patients that need to be screened by an intelligence and not by a human being. So right now, this program is actually FDA cleared by the US, and it has a very high sensitivity. For those of you that know what this mark is, it means it's been recognized as being very safe. It's been authorized in Canada. It's been authorized in the UK, and it's also HIBA, which means it's very secure when it goes up. Everything is saved. Everything is not saved, it's actually destroyed, and it's actually pre-safe. And now the Saudi FDA has finally, after much documentation, has finally approved it here in the Kingdom of Saudi Arabia. So I took randomly from my clinic, I took 2,800 patients out of 11,000. Out of these 2,800, I put them into categories, and I found out that out of these 2,800, I wasted my time and my skills. Actually, by the time I saw the patients with severe or proliferative diabetic retinopathy. So out of these 2,800, I only found 150 patients that needed my skills, but I wasted my surgical skills. I wasted my medical skills, where a black box can be doing it, of examining 2,650 patients to be able to find these patients. That's why there's a bottleneck. A lot of patients that need our help, that need our intervention as retina specialists, we can't examine them. I mean, we cannot treat them because we're busy triaging. And this is not correct. So this is what artificial intelligence is. All these are diabetic patients. I, as a human being, I have to go and triage and examine all these patients to be able to find 1 or 2 diabetic patients to take out. I'm wasting all my energy on these normal or mild or moderate patients to be able to find the high risk. Why should I do that? Why not bring a black box? And I don't like to call it a black box because now I know exactly what it does. I call it a white box. Why not bring artificial intelligence, let it do all this work, let this artificial intelligence be able to take out the patients that need to be seen and treated, and let the artificial intelligence waste its time. And it doesn't, because it's not a human. So technically speaking, automation is the only way to screen this growing diabetes population. Remember, this is not telemedicine, totally different. We're going to be explaining why. So what does it do? It increases the access to screening and treatment. It reduces the cost because you don't need anything except a camera, which already exists, and you need someone that can take the photos. It increases the screening rate, which is underdiagnosed in the MENA region. The MENA is the Middle East, North Africa, and it reduces the burden to the diabetic patients because they have to keep coming back and back to the doctor and specialist. So it improves the patient care, it improves the outcome, it increases the efficiency, cost reduction. What do we mean by scalability? Actually, it doesn't just tell you there's mild. It tells you how far mild it is, and I'm going to be showing it to you. It doesn't tell you it's moderate. It tells you how severely moderate. And why do we mean by extensibility? Because as soon as we roll out this diabetic part, we're now working on glaucoma and we're working on age-related macular degeneration. So I'm happy to say that this is the first customized and recognized automated image analysis system. We've tried it on our Saudi patients. We had seen many programs. We brought the companies in and they never were able to diagnose the advanced stage, which we have in Saudi Arabia. So we took this program and we customized it to also be able to recognize the late stages. It serves our unique Arab and African advanced diabetic population. It differentiates those who have sight threatening from those that are at low risk. It's cost effective and it's automated, and it's now the new technology. And it will be a major facilitator in the future. And it will transform our current traditional, conventional diabetic retinopathy treatment by simply improving the level of services provided. So it's automated. It's a software as a service. You don't need any machines, nothing. Technically, they're credits, and we put them into your camera. It's authenticated by published data. You don't need to be in the hospital. Very reduced cost. We sort of did a scanning, a feasibility. We found out the cheapest, even for the Ministry of Health, it will usually cost up to 500, even though they say we don't pay. But if you take everything into account, the receptionist, the dilating drops, the nurse, even paying the doctors, that it costs about 500, which is too expensive. It's highly efficient and reliable, better than me, ease of accessibility. The patient can come at any time. They do not need appointment. Fewer human resources. It continuously checks the patient at his own convenience. It decreases the load on us as ophthalmologists. I should only be treating unnecessary exam, no dilation required, but in the beginning, I'm using dilation because of our patient population, and only 2 photos are needed. Whereas in the regular, it's usually 7 photos, which is really 14 because of the stereopsis. And the beautiful thing about it, I'm going to be showing you, it's further subclassified. So this is your traditional screening. You take 7 photos, and then again, another 7 photos, but they're stereoscopic. So you end up taking 28 images. Whereas for this image recognition by the machine learning, all you need is to take 1 photo of the disc, 1 photo of the macula, and then the left eye, the right eye, the macula, the disc. So all you need to take is 4 images. The cloud loves it, because to have 4 images in comparison to 28 images is just, you're clogging the system. So how does it work? The patient comes to your clinic or to your dispensary or to your diabetic center. You already have a fundus camera. Why did I put this? Any fundus camera that exists, it will work with it. Other programs we looked into over the last 2 years, some of them would be only connected to 1 camera. So whatever camera you have existing, even if it's not validated, it could be validated. So you sit the patient in, and all you need is just a 2-field photography. And then you have your little computer. You actually put the images in here, and then you submit it to the Saudi cloud. Why do I say the Saudi cloud? We were able to convince the United States programmers to be able to have it all here in Saudi Arabia. So even though it's HIBA, even though it's safety, even though it's secure in the States, according to the Saudi regulations, we need to have all of our information here in Saudi Arabia, and we were very fortunate. So the images are submitted to the Saudi cloud. It's rapid of both eyes, the images, and then it's automatic. And if you want to believe it, and I'll show you in a minute, it analyzes it in 60 seconds. And the report comes back as positive, red, or negative. And I showed it to you. I mean, anyone that doesn't even understand ophthalmology, if they see green, they'll tell the patient, go home. If they see red, they'll tell the patient, we need to refer you now to the main hospitals. How does it work? You set the patient down. Here's the camera. This is the person that takes the photo. It can be anyone. It could even be the diabetologist. If he's got a camera there, he can take it. It's so easy. There, and it's in the user computer. You put all the information of your client. Then you take it up to the cloud. It's secure, connected. It goes to the servers. Of course, it's going to go to the Saudi servers. And then it goes to the cloud. It analyzes in the cloud in the States, and then it comes back to our server. So everything there is destroyed, and we made sure about that. So here's your fundus camera. There's your workflow. It's your patients. Someone takes the photos, and then it goes to the cloud. It's the analytic engine. It actually interprets it, and it comes back as being recommended, no refer if it's green, recommended, you refer if it's red. Very simple. So, and this is the way it takes it. These images are all by algorithm. I'm not going to go into it. It's very complicated, but it takes these deep convoluted neural networks. It deconvolutes them, threshold, occlusion, and then all of a sudden it tells you what the risk is. So these computers are learning to recognize diabetic eye disease in the fundus photo with the help, remember the keyword, algorithm. So this is the way it comes back. What the person sitting at the computer, whether it's a desktop, whether it's a small computer, and I know now the portable ones have their small computers, you just feed it into there. If it's negative for vision threatening diabetic eye disease, it will show it as green. So you tell the patient, go home. If it's positive, then you tell the patient, you know what, you have to go visit the ophthalmologist in town, in the city. So really simple. No one has to be an ophthalmologist to understand it. So what do? You sit the patient at the camera, the images are taken, and they're sent to the Saudi cloud. This is all through the government. And then the results, and I'm not exaggerating, while the patient is sitting at the camera, doesn't have to go anywhere, the results are available in 60 seconds with easy to read, actionable PDF report. So it's no dilation needed. In the beginning, I'm going to ask everybody just to dilate until they get used to it. It's non-invasive. It's fully autonomous. What do we mean by fully autonomous? You do not need a reader. It goes to the cloud and it gives the report to whoever's taking the fundus camera, fundus photos, and it gives the patient this report to take, which comes from the States, by the way. And then no specialist is needed. It's instant results and you get an actionable report. So you improve the patient care, you improve the outcome, you increase the efficiency, you reduce the cost on your institute, and its scalability. It will tell you what level is it. And then most important, we're going to be extending it. I'm happy to say that we just recently did the Saudi version where this report is not only translated in Arabic for the patient to be able to understand, but the English, the one that comes from the US, the English version, does not tell you what time to come, when to come back. It will tell you green, go home. We were very lucky here in the Kingdom of Saudi Arabia through the help of the higher authorities where we did the algorithms. So now the patient, if it's green, it will tell him, come back in 12 months, come back in 9 months, come back in 6 months, come back in 3 months. So this is really something we're very proud that we were able to do. So what do we mean when we said extensibility? We are now doing diabetic retinopathy. We're working on glaucoma and we're working on macular degeneration. You might be very surprised if I would tell you that looking at the retina in the future, we're working on it. We're going to be able to predict Alzheimer's, cardiovascular disease, and who's going to develop a stroke. This is really very important. What's good about this solution? This is before we customized it to the Saudi population. It is all peer-reviewed publications. In the British Medical Journal, in the AAO was presented, and also in diabetes and in ophthalmology. So all what I'm telling you about, this has already been approved. That's why it's US FDA recommended. This was the latest presentation. It was actually in May of 2020 of this year. They took over 1,000 patients. And interestingly, the sensitivity, and for those of you that cannot differentiate between sensitivity and specificity, the sensitivity means that you do not miss anyone. So the sensitivity was 100%. Now, the regular, which is fine, this was done before this came out. We said the sensitivity, I'm happy with 95%. So the sensitivity is 95%. For me, as a retina specialist, board certified, I actually have a 59% sensitivity. For people that are general ophthalmologists and are not retina specialists, their sensitivity is 21. That is really an alarming number. And this is actually all the endpoints. They met the p-value. So these pivotal trial results has demonstrated that the sensitivity of the artificial intelligence is far superior to me with 35 years experience in retina. It's actually much farther superior to me because it's 95 and I only reach 60. And this applies to all. Why? I don't have time to count all the microaneurysms. I might miss an Irma. Maybe if there's a very small NVE, I might miss it. This is where this is really above the human skills. So what are the opportunities? We want to get all the diabetic patients, all the pre-diabetic patients, all the obese individuals. We want to be able to examine them, get them away from the hospitals or examine them outside the hospital. They can have a screening room there. We want to get them in the clinics, the dispensaries. This is really where the business will be mainly, because that is the best. In the optical shops, when someone goes, picks up his glasses, are you diabetic? Would you like to be examined? In the pharmacies, and then of course the recreation center. If someone cares about his health, would you like to know if you have diabetic eye disease? The measurement of success, we know that the national healthcare system has already adopted it here in Riyadh. The referral pattern is not going to be a problem, and the volume of patients are not going to be a problem. This is the way it comes out. This is what the patient takes home. He has his information, it's all there. And then he has positive for diabetic retinopathy, and it shows, that's all you need is 4 photos of the right, macula-centered, optic disc-centered, left, macula-centered, optic, and then it actually follows the ICO, it follows the international diabetic classification, and then it tells the plan. Of course, the plan it will tell only for the positive, but if it was green, unfortunately, it just says, go home. We were able to further subcategorize it. Remember when I told you about the diabetes? These are our reports. This is reports we did on our own Saudi patients. So it shows moderate, non-proliferative, non-diabetic. It will actually just say non-referable, and it will be green. We further took it. I'm going to be showing it to you. Now if here it's red, although this is non-diabetic retinopathy, but it takes the larger eye. So this one shows that it's severe. So the severe are usually referred per the early treatment diabetic retinopathy study and per the international classification, of diabetic retinopathy. This is what I mean. If you have someone with proliferative diabetic retinopathy, it will not just say 4, because no diabetic retinopathy is 0, mild, moderate, moderate severe, and then moderate, and then you have the severe, which is 3, and then you have the proliferative. So not only will it say 4, it will say 4.3. I mean, it is so precise. It starts from 4.0 to 4.9, or from 1.0 to 1.9. So it's more accurate than us as specialized retina. If a patient is ungradable due to corneal opacity, due to cataracts, there could be many reasons, or he couldn't focus, it will come back as ungradable. Interestingly, it will tell the patient, because it's ungradable, go see your doctor. These are a very minute amount, but the good thing about it, these ungradable are not counted. So you keep your credit. It is not accountable financially. So this is what we did in Saudi Arabia. What we were able to do is we took the English version, and we were able to translate it so the patient will be able to take this. So we took this, we were able to translate it. Translating it into Arabic is really very important, but we went one step ahead. I don't know if you can see it on your screen, but it says to return in 12 months. This patient technically had no diabetic retinopathy. If this patient had mild diabetic retinopathy, it would also be green, but what will it say here? It will say return in 9 months. If this patient had moderate diabetic retinopathy, which is number 2, this was 0, 1, 2. If it's moderate, if it's from 2.0 to 2.5, this is considered moderate. You tell the patient come in 6 months. If the moderate comes between 2.6 to 2.9, this is moderately severe. So you tell the patient come in 3 months. Then another report that comes out, if it's blue, it will come as red, and it will tell the patient, please go now and see your ophthalmologist. This patient, as you can read here, it says you have to come back, not to the ophthalmologist, but to get another photo in 12 months. This is blue. It means it could not diagnose it for some reason. Another important thing is you have a barcode here. So the patient, if he doesn't want the hard copy, he can scan his mobile and he'll be able to take it. In addition, and have it on his phone. In addition, it's going to give him nice advice on how to deal with diabetes, what to do with it, and it's all in Arabic. There's the English version, but you have both. You can decide on which. So this barcode will help. And this is what we've done. We have gone, so not only translated it, but we are saying that there is إيجابي لتهديد الرؤية بسبب الاعتلال الشبكي السكري, that it's positive for vision threatening diabetic retinopathy. So it all comes red. And then it tells him when he should, some advice on what to do, how to control. And then of course there's this barcode here. So this is really in a nutshell. I didn't put the video, which maybe I should have, but I thought I was limited for time, but I see that we're doing okay with time. So right now I am targeting the Ministry of Health. That's what the country wants to do with the government. We want to be able to target the clusters. I know that there are 2 clusters in the central area. There's a cluster in the western, eastern province. There's a cluster in, we missed Buraida. I don't want anyone from Buraida. I don't want them to get upset. I'm not sure why it was missed. There's also a cluster here in Buraida. There's a cluster in Hayan. There's a 3rd cluster I'm hearing in Riyadh, but right now we're talking about the cluster in Taif. Hopefully, we want to make this a service for this underprivileged people that cannot come, people that are bedridden, very difficult for them to travel. They should be able to only come to the main cities only to be treated, whether it's by laser, anti-VEGF, or God forbid surgery. We should not reach that. There's a concern, what are you going to do when you have this big influx? Well, we're going to have a big influx in the beginning, but with years, it's going to go down. If you look at the United Kingdom, diabetic retinopathy was the #1. They used this specific program, of course, not customized like we did it. And I will tell you now, diabetic retinopathy is not considered the #1. It has actually gone down and it's considered on the low scale. Then in the beginning, they were getting all these patients. The doctors loved it. The retinologists loved it. Why should I waste my time screening when a white box can do it for me, when artificial? Send me the patients that need treatment. Instead of me wasting an hour or half an hour examining a patient, dilating, waiting, blah, blah, why not utilize this half hour to be able to treat this patient and let it go? So what's our future? Right now, we're working, it's going to take at least a good 2 to 3 years. We're working now where the patient doesn't even have to come to the camera. The patient will be able to take his own fundus photo on the phone and be able to send it to the cloud. It will give him the report. If it's green, he goes and relaxes, and it'll tell him when to be able to come back again and do the same photo. at a very low cost. And if it's red, then he has to go and seek a ophthalmologist. We are now at the moment collecting all the retinologists' information that are able to treat. And technically, we're gonna on the phone, not on the phone, when he's sitting on the at the camera, we should be able to tell him which doctor to go to, because technically the doctors will be able to have more business, especially in the private clinics, rather than just treating, rather than examining. The Ministry of Health, if they're not able to treat all these patients, which they probably will not, should have some sort of a collaboration between the private clinics. And right now we are doing the algorithms for this. So I want to thank, the Ministry of Health. I want to thank the King Faisal Medical Center, and in particular, Dr. Sami Al-Harthi, for allowing me. I really tried to make it very simple. I didn't go into the complicated stuff. I didn't go into the business structure, because this is really very public. And later, if anyone is interested in the public portfolio, we have a wonderful one that we're working with Riyadh, and we're working also with the Qasim that we presented to them. So I want to thank you all. I just put this, if anyone needs any information, please feel free to send your questions to this. So I will stop here. I will give the floor now to Dr. Sami as our moderator. If any questions, and please, any questions you have, I'm more than happy. And I want you to challenge me, because by challenging me, I will tell you that it truly makes our application. I have been working on this for the last 2 years, without exaggerating, and I love every minute of it, because being able to hear these challenging questions, it actually made our application much better. Thank you all very much for your attention.
Assalamu alaikum wa rahmatullahi wa barakatuh. First, I would like to thank Dr. Salwa Al-Hazza for this nice presentation. Thank you for the audience also who is attending from different cities in the kingdom. For me, I don't have question for the right time, but I will leave the chance for my colleague to ask the questions. So please.
I don't know who's running the chat box, but please feel free to ask me any questions. If someone is reading the chat box, they can just read it to me, and I'll be more than glad to answer any questions. And I'm hoping that they are challenging questions, because I'll be able to take it back to my developers and to my collaborators, because it took us technically 2 years to really get this running. And we didn't do it from scratch. We took a program that already exists in the States. We worked very closely with them, and then we customized it. That's why we called it Saria. We customized it to the Saudi population.
Any questions?
Was there a chat box, Dr. Sami?
Yes, there's just a chat box here, but most of the question you answered. Some people asking about if this system is already implemented in other hospitals inside the kingdom or not.
Well, I didn't want to implement it. I mean, many of the private hospitals have come to me, but in all honesty, I'm more interested in getting it to the Ministry of Health. We are now about to start, hopefully in Riyadh soon. Qasim is going to follow. The reason it has not been implemented on a larger scale is simply because when the COVID hit, all the energy was put into the COVID-19, and I was involved in it. So now, hopefully, I didn't put the timeline. We're planning on December to roll it out. It's already been piloted, but now the different clusters are really interested in having it in their, we tried it on a small scale in these different hospitals, and they loved it.
Okay, in the cluster, that means you will start in Riyadh first.
Yes, already. We're going to be starting in Riyadh very soon.
Okay, they have cameras for the program, or still they don't have?
The cameras that are there. This is the good thing about it, Dr. Sami. You don't need to buy new cameras. Whatever camera already exists, we use it. This is the unique thing about Saria. You don't have to go buy cameras. Whatever fundus camera, as long as it can take photos, it can be used. Now they have, in Riyadh, they have what they call the diabetic centers. So these diabetic centers, these patients come in for their diabetic treatment or not treatment, exam. So these diabetic centers already have cameras and they take photos, but they have a problem with interpretation. And by the time someone comes in to interpret it, the patient is either lost, there's no one to call him back. Whereas with the patient is sitting at the camera, you take the photo of the patient while the patient is still sitting. You throw the actual images to the cloud, and while the patient is getting up to go, it comes out 60 seconds, and we timed it. And the patient is able to take a report in his hand, and then that desktop or the laptop, you can actually connect it to the main hospital. Let's say this was a small dispensary or a Ri'aya al-Awwaliya, that's what they're doing. You can connect it to the main diabetic center through your electronic medical records, and it will have the information there so that when the patient comes back, not only did he have a hard copy and even a soft copy on his mobile, but whatever result comes back, it's actually connected to the electronic medical records.
Okay, we have more questions here. One of the question is asking about the sensitivity in mild cases of diabetic retinopathy.
It's actually more sensitive, and I'm so happy, in the vision-threatening diseases. So the vision-threatening diseases, the sensitivity was 100%, and I showed it to you. This, I think, was at the British.
Yes.
The mild cases in the graph I showed you, it goes up to 95%, which is more than what I can do. So the sensitivity has reached 95%. Also, the specificity is also very important, Dr. Sami, because also you don't want to overdiagnose and be sending these patients and saying they're positive. That's where the specificity comes in. And then when the doctor examines them, he finds out, oh my God, they're negative. They just wasted my time, because now he's used to being pampered. So even the specificity is considered in the 90s, which is much more specific than many of the general ophthalmologists.
Okay, more questions about the screening for AMD and glaucoma patients?
Right. Well, right now, the buzzword is in diabetic retinopathy. We are hoping that once we get the culture of doctors adopting this, and you have to also remember, the doctors or ophthalmologists should not be afraid that this is going to replace them. Artificial intelligence will never replace the ophthalmologist. All it does is augments your work. It makes your work easier so that you don't have to do all the scut work. So if you talk about the glaucoma and the age-related macular degeneration, we're working on it, but we do not want to consider it. It's still, we probably need a good 18 months or so until we get the diabetic retinopathy rolling. But glaucoma is a wonderful way to be able to do it, simply because you look at the optic disc cupping. I don't want to talk much about the glaucoma and about the age-related macular degeneration because it has not been out. So there are confidential, if you will, this is still confidential, but I will tell you it is in the pipeline. And as soon as everybody adopts, I mean, if you look at age-related macular degeneration and you look at diabetes, which is more important, the diabetes is what we call the silent pandemic. It actually, patients go blind because they do not know about it. So you would rather put your efforts into the diabetic retinopathy, make it perfect for the Saudi population and the GCC and the Middle East. And once you have that rolling out, then you go and you test it on your age-related macular degeneration. All the photos that will be collected to the government. I do not own the photos. Sadia doesn't own it. Salwa al-Hazza, it's all going to be in a repository for the government where we'll be able to do more research when it comes to glaucoma and age-related macular degeneration.
Okay, questions also about who will be working on those programs, because we have also audience from as optometrists, for example. They have questions regarding what's the role of the optometrist in this program.
My God, the role of the optometrist is going to be wonderful. Why? When you get a diabetic patient, when you're doing the glasses, and the diabetic patient says to you, when can I see my ophthalmologist? You say, you don't have to see ophthalmologist. If the optometrist can acquire a fundus camera, and I'm sure it's there, they can move it into their optometry clinic. The optometrist would be the best people to take these photos, or to have the photographer, and to be able to sit with the patient and explain to him, you do not have vision threatening disease. You have mild, very simple, mild, moderate, severe, or proliferative. Or you need to come back for a follow-up, or you have severe and proliferative. We're going to refer you now to the ophthalmologist. So the optometrist, wherever they're at, this is going to be a wonderful exam, because when your diabetic patient comes in for their glasses, why not be able to tell them if they have vision-threatening diabetic retinopathy or not? This will actually complement all the optometrists in doing their actual exam. This is really, thank you for that. And I really want to engage the optometrist. Technically, why not have the optometrist doing it? They could easily be a big help in diagnosing and helping interpret the diagnosis that comes from the cloud.
We have questions regarding Optus camera. I think you
Yes.
have answered the question. You have answered the questions.
Not really. Thank you for bringing this up. We tried to use it on the Optus camera, because the Optus camera takes really wide in the periphery. The images were not that well. So at the moment right now, we do not recommend getting images from the Optus camera, because it will all come back as ungradable. We prefer just a regular camera. No OCT or anything is needed, because the good thing about the regular cameras is this program, and as I showed you, the person that had proliferative diabetic retinopathy, he also had macular edema. So this program not only diagnoses the different levels of diabetic retinopathy, but it will tell you if there is diabetic macular edema or not. And I will tell you that many people are unable to diagnose diabetic macular edema. I can't tell you the number of patients that have come into specialists and they just look for NVEs and MVDs. The patient might have macular edema. They are not able to diagnose it because it takes stereopsis. It has to be 2. Now, this particular program does not have stereopsis, but with feeding it enough diabetic macular edema photos, it is able to diagnose the macular edema at a very, very high sensitivity and high specificity rate.
Okay, we have one question. I will read the question as it's written. Some diabetic patients have severe ischemia with minimal background retinopathy and may develop iris neovascularization. How could the application catch such patients?
Thank you. That is a wonderful question, and we address that. Technically speaking, anyone that will develop iris neovascularization, the iris neovascularization does not come first. It comes in the posterior pole, and then it pours into the anterior segment. So it will diagnose it. Even severe ischemia will be diagnosed as proliferative diabetic retinopathy. So any patient that's diagnosed as proliferative diabetic retinopathy, if they should have also, in addition, the iris neovascularization, it has already been tested, and it has already been diagnosed through the proliferative diabetic retinopathy. So it did not miss any iris neovascularization.
Okay, I think we have answered all the questions that it's written here in the chat. We will give the chance for 2 minutes more for the colleagues to ask more questions.
Please, the more questions you ask me, the better it makes the application for our Saudi population. And remember what I mentioned, it's a software as a service. It's available 24 hours, 7 days a week, 365 days. You don't have to worry about your doctor going on leave or your doctor examining other patients and waiting. This application will give you the results in 60 seconds, 365 days around the clock.
Okay, we have one question here, but I will modify the questions. This application can be used in other facilities or other ministries, like Ministry of, for example, for the driving license, for people who is need to have medical reports and eye to be checked. I mean, can we use it outside also the Ministry of Health?
Oh yeah, this is going to be used everywhere, but you have to remember, this program, as we mentioned, is for diabetic retinopathy. It has nothing to do with getting a visual acuity. There are programs out there which are so easy. This particular program is only geared at the moment right now for diagnosing diabetic retinopathy. If it sees anything besides the diabetic retinopathy, let's say a retinal detachment, God forbid, or sees, it will say ungradable, and it will tell the patient, go to your ophthalmologist. So in a nutshell, this program has been programmed. They've been working on it for the last 10 years. I've worked on it for the last 2 years for our Saudi population, is mainly at the moment right now for diabetic retinopathy.
Okay.
Diabetic eye disease.
Okay. Do you recommend any specific camera for this program?
This is the unique
one of the
thing.
questions.
Yes, it can use any cameras, but I will tell you at the moment now, there are cameras that are automated. You know, it's like when you go into your Mercedes car, your steering wheel comes out to you, your chair. There are now cameras that are fully automated. I will tell you that this, and I have no interest, no financial interest, but I will tell you that this has been tested on many cameras and all these cameras, but the latest cameras that they have been tested on have been what they call the Optimed, which is the handheld camera. Beautiful images have come out. And another camera that it was tested on, what they call the Centriview, the Eodon. Remember the one I showed? I didn't want to go into the camera, but someone asked and I have to answer. That publication that came out was actually on the Eodon camera, which showed the 100% sensitivity. So if you don't have a camera and you want to buy a camera, make sure the camera that you buy, it can be any camera, but make sure the camera that you buy has automatic software. Whereas when you sit the patient down on the camera, you shouldn't have to go to the right eye and then go to the left eye. And then you shouldn't have to center it over the optic disc or the macula. You put that into your camera, that program, you sit the patient down, and within less than a minute, it should be able to take the 2 images for the right eye, the left eye, the 2 images for the right eye without you having to do anything, simply by the patient touching his forehead to the camera. There are now cameras available in the Kingdom of Saudi Arabia that are automated, and they do all the work for you. So you don't even need a nurse or a technician. You just need a body to be able to talk to the patient and say, listen, put your head in, and it's done.
Okay, one more question about King Faisal Specialist Hospital. Is there any specific date to start the program there?
what I mentioned, why would you want to start a program at the King Faisal Specialist Hospital or at the King Khalid Eye Specialist Hospital or these specialized hospital? As I mentioned in the beginning, this is a service. We want to go out to the patients that can't reach these hospitals. So our main aim is to go to the Ministry of Health, go to the suburbs, be able to diagnose these patients and bring them in. If it comes out as red, bring them in to the main hospital. So we're not targeting the specialized hospitals. We are targeting the dispensaries. We're more interested in giving it as a service to the underprivileged that cannot drive or go. And I think Dr. Sami will tell you, I mean, there are the suburbs in Taif, they could be up to 400 kilometers away.
Yes.
Can you imagine a patient driving 400 kilometers and at the end you tell him, you know what? You have no diabetic retinopathy. Come back in 12 months. This is annoying. Or you know what? You have mild. Come back in 9 months. Why not? In his little town, as long as you have a camera there, and as long as you have internet, you make sure you have good internet. As long as you have a camera and internet, let him leave his house, go walking, or maybe a 5-minute drive, get himself triaged, and he only comes to the main center, like the King Faisal Medical Center, only if the artificial intelligence tells him it's red and you do have vision threatening disease, please drive 400 kilometers, because when you reach there, they are going to treat you and they are not going to diagnose you. You've already been diagnosed in your hometown.
Okay, thank you so much. I think we are done now. It's 8:30. شكرا للزملاء في إدارة التدريب والابتعاث بتدريس الصحية في الطائف. شكرا للحضور. الشكر الكبير للدكتورة سلوى الهزاع على مشاركتنا خبراتها اليوم. نتمنى لكم التوفيق دائما. زملائي الأعزاء بمجمع الملك فيصل الطبي، شكرا لكم على التنسيق والترتيب الاجتماع، ويعطيكم العافية جميعا.
Thank you very much, Dr. Sami. I have never seen such a good team, so professionalism from yesterday contacting me. And I truly want to thank you from the bottom of my heart for allowing me to explain artificial intelligence, which is now the buzzword, especially now with the G20, with the global summit just ending. We were actually part of it. Now, this is going to be the cutting edge solution. And if we don't jump on the wagon and go with this artificial intelligence, then we haven't done our work. Thank you very much.
Thank you, Doctor. Thank you. Thank you very much for.
يعطيك. خلاص خلصنا؟
أنا أطلب المايك للأستاذ عمر مدير إدارة الشؤون الأكاديمية. كم موجود معنا؟
السلام عليكم ورحمة الله وبركاته.
عليكم السلام.
الصوت واضح؟
واضح. تفضل.
أهلا وسهلا بك بروفيسور الدكتورة سلوى الهزاع. أهلا بك.
يعطيك
الله يعطيك الصحة والعافية. طبعا بس المعلومة للحضور، الدكتورة سلوى هي أستاذة بكلية طب جامعة الفيصل.
صحيح.
وأستاذة مشاركة بطب العيون بكلية الطب بجامعة جنوب كاليفورنيا، وكمان عضو سابق بمجلس الشورى.
شكرا لك. كلها تروح وتجي، لعلنا بس إن شاء الله في هذا الوقت نقدر نخدم مرضانا، مرضى السكري، وهي كلها تبدأ والله بالصحة. هذا اللي أتمنى إن شاء الله.
الله يعطيك الصحة. احنا سعيدين الصراحة بوجودك معنا عبر منصة إرادة. كمان نشكر الدكتور سامي الحارثي رئيس قسم العيون بمجمع الملك فيصل على حرصه الصراحة على حضوره وعلى إقامة دورات تخص العيون واللي تستهدف الأطباء والتمريض وتخصص العيون بالتحديد. شكرا دكتور سامي.
العفو عمر، شكرا لكم، شكرا للزملاء أيضا الإدارة لديكم.
الله يعطيك
العافية
الصحة.
إن شاء الله.
الله يعطيك الصحة والعافية. طبعا هي الدورة هذه الصراحة تعتبر الأولى من نوعها عندنا في صحة الطائف. طبعا الهدف منها اللي هي توعية بتأثير السكري على العين واستخدام الذكاء الاصطناعي في الكشف المبكر في شبكية العين. أتمنى دكتورة سلوى تكوني معانا، لازم توعدينا، لازم يكون لنا لقاء قادم بإذن الله.
والله ما عندي أنا أبلشت الدكتور سامي، بالعكس أنا زي ما قلت لكم أنا يهمني جدا نطلع للأطراف. أنا ما يهمني بس نروح للسبيشالايز اللي سأل، نبغى نطلع لوزارة الصحة، نبغى نطلع للأطراف، نبغى هذه تكون خدمة لمريض السكري. وبالعكس بتشجيعكم هذا الشيء بإذن الله. وأتمنى تكون The Health Cluster المجمع الطائف يكون هو من أوائل اللي يستعملون الذكاء الاصطناعي، لأنه هذا اللي الحين أصبح، وهذا حيسهل أشياء كثيرة، حينزل الخاص. وأنا ذكرتها للدكتور سامي أن اليوم لما قدمتها very educational. There is a business part of it. If anyone is ever interested أقدر أقدمها يعني لناس مختصرين لهذا الشيء. The business part of it. I think this would really help in actually having a business portfolio to all your diabetic patients اللي يكونون في منطقة الطائف بإذن الله.
بإذن الله بمشيئة الرحمن. طيب دكتورة سلوى، هذه شهادة شكر باسم مديرية الشؤون الصحية.
مرة حلو، الله يعطيكم العافية.
الله يعطيك الصحة. صراحة نتمنى إنه زي هذه الدورات نقيمها في إحدى القاعات اللي في صحة الطائف عشان نستفيد أكثر، بس أظن جائحة كورونا أعطتنا خيارات أكثر إنه حتى وإحنا في بيوتنا ننفذ الدورات التدريبية عن بعد.
صحيح.
فعاد نسأل الله إنه أفدنا الناس، وكمان حتى إحنا استفدنا من هذه الدورة. شكرا دكتورة سلوى، وإذا كان عندك أي تعليق تفضلي.
بس إن شاء الله أتمنى إني أزور الدكتور سامي عن قريب في الطائف إن شاء الله، وأوريه الارtificial intelligence بواقع، بحيث يدخل مريض وأشرح له إياها بواقع المريض، كيف المريض يقعد يجلس، ناخذ له الصورة نرفعها للكلاود، ترجع من الكلاود خلال دقيقة ونص ويكون معاه الريبورت. هذا جدا مهم. فمتى ما الدكتور سامي حاب إني أزوره يعطيني خبر وأنا بخدمتكم.
إن شاء الله تشرفينا دكتورة، وإن شاء الله يكون لك دعوة رسمية من المستشفى ونطبق جميع الكلام اللي قلتي عليه على أرض الواقع بإذن الله.